Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today on Healthy Minds,
we used to say the horrible thing to our patients, come see me when you are ready. I've got nothing to offer to you as a physician unless you are ready to change your behavior. Terrible thing to tell to a patient, but the reason for that was because we did not have any technology to really work with people who were highly ambivalent about their use. We can start working with somebody who has zero interest in changing anything in their lives.
that's today on Healthy Minds. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Every day, more than 90 Americans die as a result of an overdose on opioids, and over 2 million Americans are addicted to prescription pain relievers, heroin, and synthetic opioids. Today I speak with leading expert Dr. Petros Levounis about the opioid crisis. Petros, thank you for joining me today.
Thank you for having me here, Jeff.
I want to jump in and talk about what caused this terrible opioid crisis that we're living through right now.
Obviously a huge issue these days, not only in the US, but abroad as well. And the way that I see it is that there were three major forces that came together in a perfect storm that gave us this huge epidemic that we're now going through. The first part had to do with a medical mistake. At some point, maybe around the 1980s or so, we thought that people who have no genetic load of addiction, whose parents are not addicted to opioids or anything else, people who were not self-medicating any kind of psychiatric problems or uncomfortable conditions like depression or anxiety, and people who were not down and out, living in drug-infested neighborhoods, are safe. We somehow thought that these are the true causes of addiction, so in the absence of any kind of genetic load, in the absence of any kind of psychological problems or environmental, social stressors, the risk of addiction would be negligible. Huge mistake. And it was actually supported by an article that was published in the New England Journal of Medicine in January of 1980 that gave us a ratio and said that out of 12,000 people who are going to be using opioids, four are going to be addicted to the drug.
So we as a profession didn't understand the risk for anybody that taking these medicines are putting that person at risk of addiction.
Absolutely. That was a huge, huge mistake. It turns out that that article that everybody refers to, it's one of the most frequently cited articles in all of medicine, and it's not an article at all. It's a letter to the editor. It's 10.5 lines. 10.5 of the most damaging lines in all of medical literature. It's really astonishing. And one of the authors very recently actually said it was a huge mistake. So that was a medical mistake. We really thought that the majority of people would not have a problem with opioids. So the mantra was prescribe away. I started medical school in 1986, and it was very, very clear that if I were to be one of those forward-thinking, new age physicians, not like one of those goons of yesteryears like my father, any pain, opioids, high-dose opioids, nobody should be in any pain. And why? Because the risk of addiction is 12,000 to 4.
So it's safe to use, we thought, incorrectly, and who would want somebody to be in pain? So treat the pain.
Right. I believe that the majority of people who subscribed to this idea had the heart in the right place. They really did not want to see people suffer, but it was a mistake, a huge mistake.
So
then enter the pharmaceutical industry, who thought that this was music to their ears. So we have the evidence there, those 10 and a half lines of evidence. And so they started putting ads out there that promised the world to people. If you had lower back pain, osteoarthritis, any kind of chronic pain, boom, opioids, high-dose opioids, you'll be just fine. And they're really kind of, you can see those ads having these beautiful people emerging after opioid therapy and looking so good and so functional, which of course was anything but.
So then bring us to today.
And then the third part of it has to do with the neurobiology of the brain itself. But ultimately, addiction becomes the hijacking of the pleasure-reward pathways of the brain. And once that part of the brain, the more primitive part of the brain, has been hijacked by drugs of abuse, it remains so for a long, long time, if not for the rest of the person's life.
So taking the drugs, whether or not a person has a family history of chemical dependency, alcoholism, taking the drugs puts the person at risk of it being hijacked, to use your terminology, hijacking the brain.
Right, that's exactly right. It's one of the forces, of course, if you have the genetic load and if you do have the psychological predisposition and if you do live in a more vulnerable environment, your risk of addiction goes way up. But it's foolish to think that the molecule itself is not strong enough to give you the addiction. Very similar to nicotine, if you want to make the analogy with tobacco. If, let's say, a 16-year-old has no genetic load of smoking, has no ADHD or depression or anxiety, and has a peer group that doesn't smoke cigarettes, would it be okay to go up to that 16-year-old and say, smoke away? You can smoke all the cigarettes of the world you want, and you will never become addicted to nicotine. Why? Because you don't have those true causes which we some time ago thought were the only causes of addiction.
Right, but the nicotine itself and the opioid itself are causes in and of themselves of addiction.
Correct.
Petros, I'd like you to speak about the transition from pills to heroin.
These days, we may be seeing a slowing down of the prescription opioid epidemic. We see with all these interventions that we have, naloxone for the treatment of acute overdose, buprenorphine for the treatment of opioid use disorder, and all the things that we can offer, the prescription monitoring programs, we may be seeing a slowing down of the prescription opioid epidemic. However, this comes a little too late for a number of people who have already been addicted to opioids. So somebody is addicted to opioids, and then you take away the pills or make the pills much more difficult to obtain. What is she or he going to do? Heroin. Heroin is cheap, relatively easily available, especially in places like New York City and Baltimore. It's very pure these days, which means that you don't necessarily have to inject. You can use it intranasally, and you get almost the same high as you would intravenously. So we see an explosion of heroin use and deaths from heroin, which is, of course, incredibly alarming. In our clinic, we used to see 80% prescription opioids and 20% heroin, and clearly today we see 50-50.
So the intervention to reduce the availability of the pills may have the positive effect of making people less likely to become addicted, but has had the negative effect of people who are addicted. Some of those people, instead of seeking help and treatment, are then making use of heroin, which is just as, if not more dangerous than the pills.
That's right. I want to say that these interventions that we had for the prescription pills are good interventions. I've been part of these efforts. I'm not saying anything bad about that part, but this is an unintended consequence of the work we've done with the prescription pill side.
Right, which makes it even more important to get the message out that treatment is available. Don't suffer in silence. Get help.
Absolutely.
Now that we're at this point where so many people are suffering, what should people do?
Okay, it's two parts to it. The most important part has to do with prevention. Educating our primary care physicians, nurse practitioners, physician assistants, dentists, not to liberally prescribe opioids. There are, of course, a lot of regulations these days. The prescription monitoring programs have made a lot of advances, and these primary care providers are now beginning to become much more aware of the potential of addiction.
And even for the general public to be aware that if somebody is thinking they're in pain, somebody's thinking of prescribing them an opioid medicine, to say, wait a second, are there other alternatives that could help me without the risk?
Exactly. Opioid is a tough addiction, for sure. One of the toughest ones we know. The good news here is that there are safe and effective treatments that can very well address the opioid addiction. In this particular case, we have medications. We have medications that are strong, that are powerful, and they can carry a lot of the burden of illness on their shoulders. We're not always that lucky in addiction. We've got nothing for cocaine, we've got nothing for crystal methamphetamine, we've got nothing for cannabis. But when it comes to opioids, we've done well. And we do have 3 FDA-approved medications that should be used for the treatment of opioid addiction.
Tell me about those medicines.
Classically, in addiction pharmacology, we've had 2 major routes of how to go about helping somebody with medication. On one hand, we have an agonist treatment, as we call it, which is medications that go into the brain and they activate the system in a way very, very similar to the drug of abuse, and therefore the cravings come down. Classic example of that would be the nicotine patch. You slap the patch on, you get the nicotine, it's an agonist treatment, your cravings come down. On the other end of the spectrum, we have antagonist treatments, naltrexone for opioids, where you give a medication that blocks the receptors. And when somebody's on naltrexone, they try to shoot up heroin, they don't feel anything. After a while, they say this is too much money, too much trouble, too much legal exposure, and they stop using.
So it blocks the effect of the drug of abuse.
Right, it just gives you a shield. The major advantage in our field over the past several years has been the introduction of a third strategy, and that's a partial agonist. And what a partial agonist does, buprenorphine specifically for opioids, is a little bit of both, or actually a lot of both. On one hand, it gives you that shield, it blocks the receptors so you cannot shoot up and get high, but at the same time, it activates the system at the 40% level, and that is very effective in cutting down the cravings for the drug.
So it really helps in both directions.
Yes.
For the person. So if somebody is addicted to an opioid, what should they do? How do they go about getting treatment?
They should go and see their doctor. That's the first step. Someone they trust, whether it's a primary care physician, maybe a psychiatrist, somebody who can help them.
So you want to find somebody who has expertise in chemical dependency, including the ability to prescribe buprenorphine, and also there's additional treatment along with the medicine, talk therapy, self-help groups, and I'd like you to speak a little bit about that additional treatment.
In general, having psychosocial supports is a great addition to any kind of pharmacological treatment, whether that's depression or anxiety or alcoholism or opioid addiction. And that's a statement, that's a take that we have that I fully support. But something needs to be mentioned specifically about the medications for opioid use disorder, for opioid addiction, and specifically buprenorphine, that they are so strong. Buprenorphine is such a good medication, such a strong medication that can really do a lot of work towards treating the addiction. What do I mean by that? If I have a patient who comes in and says to me, you know, doc, I will never go to groups, I will never go to psychotherapy, no hard chairs for me, no meetings, just forget it, that's not gonna happen. Just give me my pill and send me my merry way and I'll be just fine. Is it ethical for me to do so or not? When it comes to opioid addiction, it is. Because now we have enough studies that show that even in the absence of any kind of psychosocial support, the medication is strong enough that it can carry a lot of the burden of illness on its shoulders.
So taking this medicine in and of itself really can help people. That being said, ideally, we'd want to have the additional support of talk therapy, self-help groups. But for those who that may not be possible or may not be desirable, the medicine itself can help get them over the hump.
Yes, and I want to echo what you just said. It's not just a matter of not wanting to do this other support. Some people do not have access to them, either financially or geographically. So it's not just I don't want them, it's maybe I cannot really have those other supports.
So to begin treatment with the buprenorphine, somebody's addicted to an opiate. They go to their own physician and say, "Doc, I have a problem, this is what it is." And he or she makes a referral to a specialist who can prescribe buprenorphine. So they go into the office. What happens?
We need to do an induction on buprenorphine, and what that means is that the patient has to be in partial withdrawal before we can safely give the first dose of buprenorphine. This is something that you learn how to do if you're going to be prescribing buprenorphine, nothing particularly complex. It's just that the medication is such that if you give it to somebody who's not withdrawing, for somebody who's just fully physiologically dependent on the opioids, then you may precipitate withdrawal, and that would be a very painful experience for the patient. Just a technical aspect of how you start somebody on buprenorphine.
So anybody who's able to prescribe buprenorphine knows how to do this.
Exactly.
And done carefully, it's something that people can get through.
Right. I just want to say, though, that we hope that it's not just specialists who would be able to prescribe buprenorphine. We would very much like to see primary care physicians. This is not brain surgery. This is not rocket science. I mean, this is pretty straightforward medication prescribing. So family docs, OBGYN, pediatricians, when it comes to adolescents, should be able to prescribe buprenorphine.
So really any physician or other healthcare professional has the ability to do this with proper training.
Correct.
So how does the management of pain fit into this big picture of treating the opioid addiction?
Buprenorphine itself does have some pain-relieving properties, does have some analgesic properties. So for somebody with minor pain, maybe you are able to kill two birds with one stone and one medication taking care of both. People who suffer from more severe pain syndromes do need to see a specialist, do need to see somebody who has special expertise in pain management, and then the picture becomes somewhat more complex. These days, we do have interventions in pain management that they are much more diverse than we had before. There are interventions that people do, and there is psychotherapy sometimes that works for pain management. We don't have to simply just give opioids to treat somebody's pain.
And it's important for the person to let the pain specialist know that they have a history of being addicted to the opioid. This is particularly dangerous for them to be prescribed a new opioid.
Yes, that's correct. On the other hand, if somebody breaks their arm or they need to go into surgery and they need major league analgesia, then absolutely we do prescribe the opioids, even if you have an opioid addiction, and that's the correct way to go. There's some popular books that say if you've been addicted to opioids, then you should never have any opioids again, and you should go through surgery without opioids. No.
Under controlled circumstances,
Absolutely.
in an appropriate situation, it's okay to take it.
Yes, with good follow-up. That's the key part. It's not so much what kind of opioids you're going to give around the time of one surgery, it's what are you going to do with this patient after the whole surgery is done.
I want to ask you about something that we in the field refer to as dual diagnosis, which is a combination of chemical dependency and another psychiatric condition such as depression or anxiety disorder.
There are several people who suffer both from an addiction and some other psychiatric disorder. It's not 100% that every addict also suffers from some kind of psychiatric condition, and it's not 100% that every person with a psychiatric illness also suffers from addiction. It's about 1/3 to 2/3 of people with a psychiatric illness will also have an addiction, and 1/3 to 2/3 of people with addiction will also have a psychiatric problem. Now, we used to spend a lot of time thinking about the chicken and the egg. What came first? And a lot of emphasis, is it the addiction that started, like say alcohol, and then the person became depressed because of the alcohol use, and therefore we should really treat the alcoholism and then the depression will go away? Or the other way around, the person, let's say, was anxious, depressed, and they start self-medicating their psychiatric problem with cocaine, and therefore we should really focus ourselves on the treatment of depression and anxiety, and then the cocaine would go away. These days, we don't really believe that. You have to do both.
You have to treat the whole person.
You have to
do
the whole person, and you have to treat the mental illness, and you have to treat the addiction as well. Only in very, very extreme circumstances where you're so convinced that one of the two problems is so primary, you may get away with a single treatment. The majority of people who suffer from both an addiction and some other psychiatric condition will need two treatments.
When somebody is in recovery from an opioid addiction, are they able to safely use other substances, such as alcohol or marijuana or other drugs of abuse, or would that lead them back to further addiction?
We have to separate that into a pharmacological part and a psychological part. Pharmacologically, absolutely. They can use that. It's nothing dangerous about the systems are relatively different. And also, even if the systems interact pharmacologically, if the person has been sober for a while from the opioids, then they can use alcohol and that would be safe. So pharmacologically, really, there's not that much of an issue. Psychologically speaking, it is. Because if somebody is working hard on their sobriety, let's say they are following a mutual help program like Narcotics Anonymous or Alcoholics Anonymous, then starting to use other substances of abuse, other psychoactive substances, may very well roll them back to a life of drinking and drugging that they had before.
So as a general rule of thumb, you would recommend that somebody who is in recovery from any type of addiction, including opioid addiction, really be very careful about avoiding the use of other potential substances of abuse.
I like your language, be very careful. That's a good way to put it. It's not a no-no, but being very careful is a good starting point.
So somebody out there who has a loved one that they know is addicted to an opioid, and they're concerned, they've tried to encourage him or her to get treatment, and the person's really refused treatment. What should that person do to help their loved one?
Let me just take a step back in this question. We used to say the horrible thing to our patients, come see me when you're ready. I've got nothing to offer to you as a physician unless you are ready to change your behavior. Terrible thing to tell to a patient, but the reason for that was because we did not have any technology to really work with people who were highly ambivalent about their use, or even they had no interest in changing anything in their lives. We're delighted that we have developed this technology. It's called motivational interviewing, and we can start working with somebody who has zero interest in changing anything in their lives. There are very specific tricks of the trade there. You try to find a tiny discrepancy between where the patient is at and where the patient would like to be, and then capitalize on those discrepancies and get the person to be confused, get the person to be ambivalent as a starting point before you move on and you start working with that ambivalence. It's a little counterintuitive for us psychiatrists who have been trained how to resolve ambivalence, how to get people less confused about their lives. But in this particular situation of the very, very early stages of motivation to change, then being confused may not be a bad thing.
What you're describing is a person does get to the office, really doesn't want treatment, but there is a technique that we have in our field called motivational interviewing, which is, as we're getting information from the person, try to tailor the conversation to a way to help move them towards being motivated to getting treatment.
Correct.
I want to ask you about the future of treatment. We currently have effective treatment, but what do you see down the road in terms of future advances in our ability to help people?
I think the major focus here would have to be back to the prevention part. Let's try to turn off the big pipeline of the pills so that the people stay safe. This being said, we would love to have more medications. We would love to have more effective medications with less side effects. We'd like to have different formulations of the medications so that they can last longer, so that you don't have to take them every day, but you may have to take them maybe once a month or so. So there are several avenues that are being explored as we speak about the medication treatment of opioid use disorder.
The take-home message is that people do get better with treatment. And I'd like you to expand upon that message.
Unfortunately, there's a myth out there, and there are pockets of the population that still believe that myth, that once you're addicted, you're doomed, and there's nothing that can be done about you, and basically forget it. And that's not the case. Addiction is chronic relapsing illness, very much like a number of other chronic relapsing illnesses that we know, including diabetes and high blood pressure and the like. Does need attention over a period of time. It's not something that you can fix really quickly. You have to follow the patient for some time, but there are safe and effective treatments that work.
With help, anybody can get into recovery from their addiction.
Yes.
Petros, I want to thank you so much for joining me today and for the work that you're doing to help so many people.
Thank you so much for having me here.
With current methods of treatment, recovery is possible for anyone. With help, there is hope. Until next time, I'm Dr. Jeff Borenstein. Goodbye. Do not suffer in silence. With help, there is hope. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. If you would like to watch our expert interview in its entirety, log on to bbrfoundation.org/healthyminds.